I apologize. I don't know what happened, but I just got a notice that it was not broadcasting. So we've hit the start broadcast button again. It is recorded, so I don't know if you would like to go back, Angela, or if you'll be able to pick up from where the recording is. It's totally up to you. I apologize, everyone. I'm not sure what happened, but thank you for reaching out and letting me know.
Okay, well, in the interest of time, I'm happy to just step back and do a kind of an abbreviated so that we don't lose momentum, and then the recording may be a little bit more detailed. How's that, Cody?
Yeah, it does look like they could see the slides, but there was no sound.
Okay, all right, so then we'll back up just a little bit, Karsten, maybe one more. Let's start here. We're going to take it from here, but not as detailed, knowing that the recording will kind of help you out there. So again, importance of grants for rural hospitals. This is healthcare access barriers. Funding can be used for staffing or to address burnout and turnover, and of course that rapidly changing technology. We know that it's super important for rural hospitals to have technology, but limited resources make it difficult to keep pace with updates. Grant funding can bridge the gap there. Next slide, please. Okay, so just quickly today, we're going to take some time to inform you of upcoming and current grant opportunities. We're going to give you some actionable strategies, and then we're going to talk about success examples so that you can be inspired. Next slide, please. Okay, so this is the big one, and if you saw this slide, maybe you've had a chance to read it more in detail. We are operating under a continued resolution, so the budget does extend through March 14th. But regardless, there are some consistent themes that we expect to continue from the Department of Health and Human Services, Health Resources and Services Administration, which is HRSA, which funding will be directed towards telehealth, community health centers, and of course, substance abuse, and just a variety of opportunities for rural healthcare in general. And then the Substance Abuse and Mental Health Services Administration also is a great opportunity for rural hospitals to address those behavioral health needs in your communities. Congressionally directed spending, we also expect as of today for that to continue. That is a process that involves developing a relationship with your United States representative or senator to identify and fund projects that are meaningful to your communities. Next slide, please. So these are some examples, certainly not all inclusive, but some examples of opportunities that are, one, open, you can see some due dates there, and two, have been forecasted. A couple of opioid response opportunities, an opportunity for those of you in the Delta Health region, or the Delta region rather, of the United States. And then that first one is the U.S. Department of Agriculture's Distance Learning and Telemedicine Grant. That is a great one that will apply to many of you because it allows for equipment and hardware telehealth technology in your rural communities due March 6th. For the forecast, those are just opportunities that have been listed in grants.gov, which is the repository for federal grant announcements. Those are agencies that have given us a heads up that they may be coming. As you can see, the January 7th, that date has passed. However, just know the agencies are simply giving you a courtesy heads up and are not held to those dates. Next slide, please. So I wanted to point out the last slide really spoke to the Department of Health and Human Services, which is the obvious place for you to be looking for rural health funding. But don't discount the opportunities that are available through other agencies. Now, again, you see Distance Learning and Telemedicine Grant under the Department of Agriculture, but there are several opportunities for rural facilities and rural hospitals to tap that funding for the benefit of your communities. You know, we're not going to dig into these opportunities specifically, but rather just understand that you can also be looking at departments of education, labor, and justice to further your strategic goals as it relates to population health, social determinants of health, and telehealth. Next slide, please. So how do you get started? I know this was a lot. That's a lot of information, but where do you go and how do you get busy to tap these funds? The first thing that I'm going to suggest to you, particularly if you're new at grant funding and grant seeking, is to make sure you have all registrations in place. The federal government does require a SAM.gov and grants.gov registration to submit applications. And in the case of state funding, some states, not all, have systems that require registrations as well. My suggestion here is to check these registrations even if you believe you have them. Make sure that the person that was the contact person is able to access it, credentials are active, and that person's still at your organization. The worst case scenario is to develop a fantastic grant proposal and not be able to hit that submit button. So do check those registrations. And then assemble a core team. You know, many rural health systems and hospitals don't have a grant writer. If you are, you're fortunate, that's wonderful. But grant seeking is not dependent on that. Assemble that core team to understand who would need to be in the conversation to say, this opportunity makes sense for us, to vet potential funding opportunities. That's typically executive leadership, clinical leadership. It can be even folks from finance and procurement. So you want a diverse group of stakeholders internally to say, this makes sense for us before you spend the time on an application. The other thing you can be doing today, and this is something I've done as a grant writer and it has served me well, is to develop some writing in advance. Now, I preface that with every application should be customized and specific to the guidance that you're responding to. That said, things like data and needs. I've never seen a grant application that doesn't ask you to describe your need. So writing some paragraphs or pages on the demographics of your community, for example, and updating that data on every 6 months or annually as it's available. Those things can really position you and take some of that workload off as you're developing applications. Organizational description is the same thing. Your organization is what it is. Of course, you want to update it as things change, but having that writing at your fingertips can prove really valuable. And the last thing as you're thinking about and laying this groundwork for grant seeking is look at your partners. We're seeing more and more grant applications that are requiring consortiums, for example. The good news is for you all in rural communities is that you probably inherently have these partners because you know one another many times, and you simply have to pool resources to get things done. So you may be ahead here with those partnerships. What I would suggest is to talk to those partners, tell them you're interested in seeking grants and there may be partnership opportunities, and figure out how that can be approved from their side. Many applications require, for example, a memorandum of agreement, so knowing who has to approve that and sign that in advance will save you some time. Next slide, please. So 5 steps. You know, you've laid the groundwork, so what do you do now? How do you figure this out? The first thing I'm going to tell you is that you need to identify your needs. Now, certainly, it's very easy to slip into the mindset of, wow, there's $1 million. What can we do to get that? And I'm not going to tell you that doesn't work sometimes, but it's really better for you to be reacting to your needs and find grant funding to match those needs versus trying to create a program to meet a grant objective. So what that looks like, you know, it's capital needs is a great example, and telehealth equipment, of course. If you have equipment that's maybe 3 or 5 years old and there are features or functions or reliability issues, think about ways that you can replace that equipment using grant funding. And the other thing I love to ask people is what keeps you up at night? You know, I know in rural healthcare, you know, you care a lot about the people you're serving, and if you had unlimited resources, there are probably things you would do today to make things better for the patients you serve. So think about those things as a potential for grant funding. And then, of course, what does the data tell you? Because I know in your gut, you may know that your nurses are struggling and they're burnout and having a hard time. But do you have some data that you can use to demonstrate that to a funder to really quantify that issue? So think about those things. Next slide, please. So once you have those needs, right, you've figured out your needs, and of course, you know, you can be a little bit flexible, but starting with those needs gives you a really good basis for identifying potential grant opportunities. So I've listed a few things here. Grants.gov, as I mentioned, that's the place to go for federal funding opportunities. The other website, and I personally use this website almost every day, is the Rural Health Information Hub, which is ruralhealthinfo.org. They have a fantastic funding section where you can sort by topic area, you can sort by your state, and even sort by what's latest in the last 30 days. And there are also some great tutorials on there on grant seeking, in addition to evidence-based practices and a lot of other resources for rural communities. And then those state agencies, I mentioned a little bit about state grant funding. It varies by state, so identify what agencies offer grant funding. May take a little bit of research and asking a few questions, But once you find where those grants are posted, check those regularly. And if you do find an opportunity that says, this might be a fit for us, your first step is going to be to review that guidance. You want to make sure that you understand all of the components of the application, but as importantly, you want to understand what you're required to do to implement the project and report on it. Because understanding that makes sure you walk into this application with eyes wide open in terms of, if you're funded, what the work is going to look like for you. Next slide, please. So you went on grants.gov, you have a potential, it looks like something you might be able to take on. How do you really assess it to make sure it makes sense for you? You know, this is really your opportunity to decide how you use your resources. If you don't have a grant writer, you want to make sure you're using your time wisely. So with that, the first couple of these are pretty easy. Are you eligible, and do you have the registration processes in place, or the registration requirements to hit that submit button? If those things are a yes, then my suggestion is to take a step back, right? Look at this grant opportunity and align it with your strategic objectives. You want to make sure that whatever the funding will require of you and whatever project you would propose is propelling you forward and aligning with your strategic objectives. So that just keeps your eye on the ball there. And then ask yourself the question, do you have the capacity to implement the project? And the easy example is that, and we're not going to talk about those today, but you know, a rural hospital may not have the capability to provide some super detailed data analysis and research, right? So just make sure you have the capacity and systems in place to apply and then be successful with implementing the grant. Is the project sustainable? Another important component, and that conversation should happen before you apply versus after you have that funding. And then this is an easy one, because all of the things above may be yes, but if you have 4 days to put that application in, it still may be a no. You want to make sure you give yourself enough time to put in a compelling application. Next slide, please. So I'm going to assume you found the perfect grant application, you've done your homework and assessed it, and it looks like a perfect way to move the strategic objectives of your organization. The next step is to assemble a team. Again, if you may not have a grant writer, and that's okay. Lots of rural health systems and hospitals don't. The trick there is to assemble that team. Get the right people in the room to say who's going to take on what section of the application. I mentioned making a list here. From my grant writing experience, what I would do is cut and paste from the guidance document all of the application requirements and put it into a table or an Excel spreadsheet or whatever works for you, and just assign pieces and parts out with deadlines. I'll tell you, it's not uncommon for applications to be developed from multiple people, right? At the end, you want to make sure it sounds cohesive, but that's a pretty standard way of operating given time and the complexity of some of these applications. And of course, regular check-ins, you know, just make sure everybody's on track. People get busy, you want to make sure on track, because deadlines are not optional in grant seeking. So next slide, please. So once you have that application together, again, one thing it's super important to do is align that application to the application guidance. We see a lot of folks, if you miss a question or two, it's going to hurt your score if it's a scored application and your chances of funding. So you want to make sure you've addressed everything in that grant guidance document. Proofread, of course, and then double check for completion. A lot of applications do require some attachments. For example, some will require that you upload proof of nonprofit status or an organizational chart. Just make sure that you've met all of those requirements. And submit on time. And I will tell you, in my book, submitting on time is 3 days early. I know life happens. It's happened to me, and it just is what it is. But if you have the option, submit on time means 3 days prior to that deadline. It gives you a chance to react, for example, if you have issues, technical issues, say in grants.gov. So you want to make sure you build in a cushion, because if you miss that deadline, there's no wiggle room. And of course, get professional help if you need it. You know, there are grant consultants out there that can help you anywhere from a full application right to coaching and just making sure you're getting all the pieces and parts together. Absolutely, again, not a requirement. Rural hospitals do this all the time, but it's just an option that you need to be aware of. Next slide, please. So I'm going to talk just for a second about how I particularly can help you. So again, I have the grant writing experience, and as AMWEL's Grants and Public Funding Program Director, we offer that experience. We know a lot of our customers and folks that want to be our customers just don't have the resources or skills to get things done. So we do a lot of project development. What projects do you have and what needs do you have and how do they fit with that grant funding, helping you through that process. We keep our eye on all things federal grants, of course, state grants too as they apply, to make sure that you're aware of those grants and then provide you with the tools and resources to walk you through that application process. We can even provide feedback on drafts, but one thing we don't pay for grant writers, and we're not offering grant writing services ourselves. There are federal procurement guidelines we're very mindful of, and we simply don't have the capacity and want the folks that we work with to build their own capacity internally, because ultimately that makes the most sense. And of course, you know, we love to congratulate you on your grants award, but you know, the idea that you got $1 million is great, but that's not where the work stops. It's really where the work begins. So we do provide some support on that end to make sure that you set up the systems and processes you need to be successful in that implementation. Next slide. So that's me, and that's it. So I thank you so much for allowing me to join you today. I'm going to note that that QR code is to my LinkedIn profile. I would love for you to connect with me. We're trying to give updates as we hear more about federal funding and grant deadlines. So please feel free to do that, or you can email me. thegrants@amwel.com is absolutely perfect, but you can also email me at angela.connor@amwel.com. Next slide, please. So with that, I'm going to turn it over to Dr. Mathur and let her tell you how telehealth has been a game changer in rural communities.
Thank you so much, Angela, for sharing your expertise and your experience. I really encourage anyone who's interested in that step-by-step to reach out to their team. Now we're going to be talking about the clinical applicability of these grants, and the possibilities are endless. I'll be speaking from the view that I sit in. I am the Chief Medical Officer of Equum. It's an acute care telehealth company founded in 2011. It's important to me as a leader in our organization to be part of the day-to-day workflows that breathe life and results from these grants. I'm a triple board certified physician. I work bedside and virtually as an intensivist, so my lens is definitely in that lane. But I also practice infectious disease in rural spaces, and I really bring that forward today here. I am from rural Maryland, La Plata, for anyone who has heard of it, or Charles County, St. Mary's County area. And I've lived in various cities through my medical training, but was most influential to me, Carson, if you could advance the slide, please, was that I did my critical care fellowship at the National Institute of Health, known fondly as the nation's house of hope, where there's no limitations on access, specialty, innovation, and they do excellent work in healthcare advancement, and resources are readily available for the rarest conditions. But what I realized is that's starkly different from even the hospital that I was born in, Maryland, or most of America. And that's really what drove me to do the work that I do now, and connect with our founder and CEO of Equum, Dr. Corey Spurlock, who has a sensational story about his rural background as well. Together, we share a passion for rural healthcare, bringing access across the country through enhancing patient logistics and also telehealth programs, and that's really the mission. Just briefly about my background. For the last 7 years, I've been involved in program implementation. We partner with over 140 hospitals between California, New York, Texas, up the Canadian border. And in this work, I've launched critical care programs, cardiology programs, infectious disease, nephrology, including dialysis and pulmonary services for virtual care, both grant funded and unfunded initiatives. The key for me is that we're laser focused on patient flow. And I think that's a unique quality measure of its own and a key KPI that we could focus on as a result from some of these grants. So the next part of the presentation is really thinking through what are the clinical and day-to-day hospital level applications, a use case. If we go to the next slide, Karsten, please. So while there's many similarities among hospitals, access to care just isn't equal. I think all of us on the call here know that today. Why should access be different in Alabama, Michigan, New York, which is where I'm speaking from? How can we increase access to care 24/7, regardless of geography? Equum is equality. Patients leaving their local community. How can we stop that while supporting the local workforce? Our goal is not to replace them, or to supplant them, it's to support them. To be able to keep patients in their local environment, we must solve for ways to bring expertise to them for complex medical scenarios, and in doing so, put in metrics not only that boost the local institution, but actually sustain the program, especially as part of these grant-funded initiatives. Next slide, please. That's where telehealth can come, and no two hospitals are the same, but I think there are some shared problems. By the end of this year, we're expecting to have a shortage of 64,000 physicians, and I just want to take a moment quickly of why that matters. And I'm mainly during my talk talking about the inpatient setting and the physician side of things, because that's where my area of focus is, but there's absolutely nursing gaps that are just as important, and other major causes in society to focus on. The US population is top heavy. It's growing at an alarming rate with an aging population. And as we're living longer, it means we're consuming hospital resources at a higher rate. In the fact, when you turn 65, you're utilizing hospital resources at 3.5 times the rate, 75, 5 times the rate, and so forth. So this, combined with the fact that our aging population often lives in rural spaces, not urban settings for a variety of reasons, cost, social reasons. If nothing's changed, no drugs, no new chemo surgeries, the aging population alone is going to increase hospital demand by about 35% over the next decade. So do we have the infrastructure to support that? Hospitals have to find a way to take care of these patients, to bring supply to meet the demand, essentially. So what is the state of our supply? Our new doctors coming in. I know there's shortages in my field in infectious disease. More doctors are retiring. Being part of a newer generation of doctors, they may want a different work-life balance. And burnout is a real phenomena. You heard Angela speak to it a little bit. And what causes it? Reports say schedule is number one, and then tasks that are not clinical. So how can we delegate some of that to offload our doctors so that they want to stay in the clinical world? And same for the nurses. Telehealth can absolutely help solve for some of that burnout. Night work is reported as one of the most common signals for burnout. I think all of us can understand why. And so I think telehealth can absolutely plug the hole to solve for some of those things. I also think that it can help us solve with the 4 S's. Staff shortages, we talked about that briefly, but more importantly, the right type of staff. I know in our work, we see ER doctors doubling as hospitalists, hospitalists doubling as ICU doctors, family medicine clinic providers splitting their day between doing admissions and clinic work. And so while they may be fully capable, it strains the system. The next big thing is service. Limited access to specialty care makes rural healthcare organizations dependent on transfers. And I'm going to talk a lot more about that in the data around it that we've worked on. Space, the right type of space. ICU beds, ER beds were unfortunately limited by bottlenecks and boarding. So late discharges are going to add to burnout and decrease patient satisfaction. So that's where this conversation of patient flow comes in, and throughput, and using telehealth as a mechanism to push patient flow forward. The final S is systems and sustainability. Not any system, it has to be the right system, the highest quality system. And we're going to talk how some of the programs that we've worked on build you back that high quality. Next slide, Karsten, please. When I think of virtual care, I think of, very briefly, 3 historic eras. There was the era pre-pandemic, where telehealth was growing at a very fast rate, 300% annually. The first tele-ICU is 25 years old. Tele-stroke programs have been in existence. Those were early adopters. During COVID, there was a panic buying period where people were adopting to telemedicine at a very fast rate. I need carts in the ICU, I need carts in the ER, and different programs were getting put up. But some of the programs launched for telemedicine were fragmented in their approach. Now we emerge post-COVID, and these programs are not connected to a larger system or a big picture enough to assist with patient flow and the continuous support that you need throughout a hospital stay. And I just want you to envision that in your mind as you think of what a grant could do for your patient flow. If I think about the current processes moving through health, I think the 2 things that we can benefit the most from telehealth is workforce redesign. I think we briefly talked about sort of access to care, and then delays in patient flow, using technology to bring the right people the right process, and then using technology to come up with the solution together. I think Angela said it as step one, just identifying your needs. What is the problem? In some of our virtual programs, in addition to telemedicine support from consultants, there are other patient-centered solutions that exist that redefine healthcare. So for example, virtual nursing, helping with admissions, discharge, staffing gaps, remote telemetry to expand bed capacity, remote safety specialists, using cameras to monitor patients for falls who are in certain risk categories. Reallocating that resource back to the bedside is a win-win, I think. These are just some of the ways that hospitals can partner with vendors to obtain solutions just at a very high level in telehealth. Next slide, please. What we really, I guess what I'm speaking of is a care continuum. Across the spectrum, it's not a single vendor that's fragmented. What I would encourage you to think about is a collaborative, connective strategy that connects the bedside, the virtual team, to reduce overcrowding, to help maybe retain transfers, care continuity, and fill in gaps, and using telehealth as a way to protocolize care so that you increase your core measures and care standardization. Even the American Hospital Association supporting vulnerable areas using some of these strategies. If you could move forward, please, Karsten. And I think support is growing. Telehealth, represents a bridge to essential services, and access to specialty care is one thing, but I think there's also conversation around reducing travel burden, improving patient education. That's fundamental. Better outcomes for chronic illnesses come when there is specialized focused care and access to specialists. Next slide, please, Karsten. The support continues to grow. The next slide that Karsten's going to pull up is a study from rural CFOs, 20 of them. This is a survey. I'm not going to read each one of these, but overall, these CFOs from critical access hospitals have a very positive opinion about telehealth, and in particular, tele-ICU and high acuity areas, saying that tele-ICU can help avoid transfers, retain patients, overall help reduce with labor costs and provider recruiting and retention. If you think about it, if you have someone that is sort of your next layer of care watching over you at night when you're the sole provider, you're going to want to stay at that job longer. It's definitely cheaper than hiring a locums or bringing somebody new. This is the alternative, is to have staff that's already integrated and fully committed to your organization. We're also able to help support with night coverage, like we spoke about. Some of the programs where we've boosted retention, patient satisfaction, and increased patient volume surrounds night coverage and the complex cases that come in during that time that lead to burnout. Next slide, please. So when I think about sort of what I want from a program, and what I would encourage you to think through is, how do we reduce leakage, retain revenue back to the hospital, improve access and expand services, and optimize patient flow? And I think the patient level benefit is clear, so I'm not speaking to that, but it does make sense that if they're able to stay in their local community, of course, the satisfaction and the feeling of being close to home has its own benefits. Next slide, please. So I like to flip the narrative and talk about, how do we keep the patients local as we get programs up and running? Is it possible? Will that work for me? In doing so, I think there's the clinical benefit, but there's also a financial impact. When you look at hospital leaders, they say that leakage, meaning patients leaving their system, is blocking them from reaching their goals. But actually addressing that leakage is more important to them than anything else, even payment models. But when surveyed, they don't have a plan to reduce the leakage. Part of the reason they may not have a plan is they don't have access to the specialist. With the right program, right people, right process, we can look at that root cause of leakage together and customize a program to solve for that individual institution need. And that goes back to sort of the tailoring and customization of a program. When we look at that leakage data, for example, with you, we come up with a plan. It doesn't take that many patients kept to generate ROI on a service line with virtual consultants, for example, and it's something that is a deeper conversation outside of the scope of this presentation. When I talk to hospital CEOs, the last metric sticks out, that it costs 90% less to retain a patient than to attract a new one. In my experience, once you lose that patient, you traditionally lose them for life. They get connected to another entire hospital organization, other consultants, other connections, and they may even share that experience with the loved one. Next slide, please, Karsten. So I'm going to talk about this a little bit more in the rural market and hit on some studies and some of the work of our own to just articulate how can you reverse this trend. What I see more often than not in the rural space is that patients are being transferred pretty frequently, and they're being transferred out for a number of reasons. The number one most common reason that I find, and this survey sort of supports it, is the lack of specialty access. And when I'm talking about that, I'm not talking about complex neurosurgery or complicated, cardiovascular specialists, but really just fundamental cardiology, nephrology, ID, pulmonary. And in the data that we have seen, patients who leave often leave for specialty access more than for the higher acuity level need at a larger institution. The second most common reason for leaving was the hospital sends them out. And you may ask why are they doing that? And sometimes the reason is good and sometimes it's not. And that's something that we work through as part of the program. But can telehealth address access, reputation, support? Absolutely, yes. And we're going to talk about that. If you can move forward, please, Karsten. Just briefly, some specialties are impacted more than more, and I just want to call this out for just a moment, because these are the common things that we find in terms of seeking out things that make meaningful change. There's a fairly recent study by Jack that looked at 3,000 counties in the US. Half of them don't have a cardiologist. And if you look at the right side of this photograph, you see this lonely heart running down a rural road, really articulating the distance that patients have to travel to see a cardiologist, 90 miles sometimes. In the rural community, 85% or almost all of them don't have a cardiologist, and patients who live in that space have a 31% higher CV risk. They're sicker. And so all of that contributes to a shorter life expectancy. Contrast that to the city, where you have access to multiple layers of specialists. And when you have them, you have a lot of them. ID has the same sort of metrics around it shared widely across different organizations about the need for rural infectious disease providers. Next slide, please. So now we're going to just go to pivot and talk about solutions. And what I want to talk about is this concept of admission decision support. In my mind, in the work that we do every day, there are 3 times of specialty support in consultants for telemedicine or telehealth. Routine consults. Those are regular co-management, ongoing collaboration with the specialist. They're fully integrated in your system. They're no different than a bedside physician, other than they're limited to their screen. Then there's urgent consults, and those are like, hey, this patient is sicker than what I'm comfortable with managing. I think they may need another layer of expertise and guidance. Come on and continue to follow them, and there might be a higher acuity level to that. And then there's the third one, which in my mind impacts leakage the most. And it's this concept of admission decision support, ADS. And these are cases that if the patient were to be seen pre-implementation of a telehealth program, they may not have been kept. It's a complex medical decision that is collaboration between the telehealth expert and the local providers. What percentage are accepted? What percentage leave again after acceptance? And what was the loss prior to the program? These are all different metrics that we look at. I think the other thing I'd love to sort of focus on is that we want to get to the patients before the decision to transfer is made. It means early and rapid involvement. That's good for the patients. It's good for outcomes, sepsis, for example, picking the right antibiotic and delivering them early. Or, hey, help me understand this increased troponin. Is this somebody that would need to transfer or not? There's also critical care telemedicine literature that supports when a teleintensivist gets involved in a patient's care in under 60 minutes, their outcomes are improved. And I think it also gets them through their hospital journey faster. And what I mean by that is take, for example, a DKA patient and how quickly they might turn around and be managed. It's managed effectively. They're able to get off an insulin drip, for example, and be downgraded from a higher acuity bed. Nurses feel supported. They have somebody they can, bounce off labs with. The ER doctor who might have been managing a boarding case, or the hospitalist who's otherwise tied up doing admissions, now has somebody actively managing an otherwise complicated case to then help with patient flow. ADS is not just limited to patients who are accepted. It also includes boarding patients. And that's to help that we know that we can't keep everybody. There's some folks that have to leave the organizations for a variety of reasons. And at least when the consultant is on board, whether it's a teleintensivist or a telecardiologist or nephrologist, the staff on site feel less insular in their practice. The nurses have support. There's mentorship for what would have otherwise been a very complicated patient. The goal is to supplement and not supplant, and I think that's a key phrase I like to share. Next slide, please, Karsten. Now we're going to just quickly look at some data. So this is our own study of a community hospital in a rural space, and this hospital had been acquired by a customer, sorry. Historically, this hospital, whenever they had a patient that was too sick, transferred out to other certain hospitals, but now those hospitals were competitors. Transferring, in our experience, mostly happens in the ER. And when you ask physicians why they're transferring out, a lot of times they have good reasons. They have good clinical reasons. The first one they say is, you know what, our ICU, our step-down unit, high acuity area is a ghost town at night, particularly at night. Maybe there's no respiratory therapist. Maybe there's no other body in-house. And that's sort of what this group expressed. If we put the patients up there who are sick, it puts us at risk, it puts them at risk. Number two is that when a patient boards in the ER, an ER doctor then becomes the critical care doc. And while they can absolutely do that, most say they don't want to, or that they have other things to do. So more importantly, I think there was another thing that the transfer center at the receiving facility, it makes it easy. They get a call, you say, here's the case, they accept them right away. And so it makes it easy for that lonely provider at night to send patients out. So in this graphic, just to set it up, the red line is the competitor transferring patients out, and the green line represents retained patients. We heard their feedback, we tried to implement most of their recommendations, wired the high acuity areas with telemedicine and made a seamless transition. So for example, when a patient felt that they needed to be in a higher acuity area or they needed to be transferred, one of the tele physicians and intensivists would talk to them, take sign out, and be immediately available. Number two, carts were available in the ER. So while the patient waited, instead of the ER being the de facto critical care physician or the high acuity manager, we instead took care of those patients, doing everything other than procedures. So notes, family meetings, orders. That helps tremendously with difficulties for the ER staff who are pulled in a million directions. We also worked some of the transfer process in our clinical process design, and really want to emphasize that early intervention is really what makes this work. Patients are much less likely to want to leave if they've already have a care plan and meet their consultants and their care team. What we saw over a 2-year period is we went from retaining 29 to 70% of cases. A net 220 cases stayed. So if you put a contribution margin, just for easy math, of 10K per case, that's about $2.2 million that would easily pay for a service, and a win-win, more importantly, for the patient in the hospital, and also for the staff burnout. This is just a small example of how when you work with clients, you can drive quality and financial viability with programs that look at patient flow and logistics and admission decision support. If you could move forward, please, Karsten. So all of that sounds amazing, but the reality is it actually takes elbow grease. And I think with the right partner, change management is really what makes a program successful. It would be amazing to get grant funding and put a program in place, but I think there also needs to be strategy around how it's implemented and continue to evolve. The problem in healthcare is really not the lack of innovation, it's the slow pace of adoption. And what we find is the change management piece is often what makes the follow through difficult. If you could go to the next slide, Karsten, and I'll sort of set this up. So we really embraced Kotter's change management principles, building a guided coalition, having each program, once a funded program comes up, have a local champion. I think Angela mentioned, assemble a team. I think this is also speaking to the clinical, the IT team, and the leadership team that puts a program in place. And then celebrating early wins. Hey, I had a great case with this new program that's up and running. You want to over communicate the message. Everyone from the ER staff, the clerks, has to be aware that this new program is up and running if you want it to win. And that part never loses momentum. The over communicating the message and broadcasting the plan has to be continuous, even when the program is successful. I think finding out what's achievable and meaningful, choosing those things as the program KPIs, helps build credibility for the program and buy-in. The other big thing is forming relationships with the staff and partly developing that as part of the workflow and making sure that when you call, you know exactly who you're meeting. It's not a surplus of 100 doctors. It's a pod of doctors that knows exactly your name. Really becoming an insider and not an outsider. And if none of those things happen, programs will fail, and that's what we've seen. Eventually, through time, there will be a cultural shift, and it just becomes the way we do things around here mentality. This teledoc gets called when we have this syndrome. It's just part of the process, and you're fully integrated, and that's when you know you've achieved success, but you never declare victory. In this particular program that I show an example, this is one Equum client that you'll see month over month as this program developed, more utilization occurred, and it directly translated into more patients retained. It takes time. It doesn't happen in the first 3 to 6 months. It does take time, but towards the end of the year in December, they were able to accept 197 patients versus 51 in the beginning. And this was a program that included critical care, infectious disease, cardiology, in a non-ICU setting in micro hospitals. The admission decision support rate was over 60% for cases that would have otherwise left, with a very low secondary transfer rate. Next slide, please. Leakage prevention, I think, was the first sort of conversation we had, but specialty access, we talked about earlier, is another key component of how you can use sort of funding and think of innovative programs. If you're sitting here today and really not sure what funding you may be eligible for, pause and ask yourself, what problem are you solving for, and what's your strategic priority with the Telehealth initiative? And if you're not ready to even answer that, that's okay. You're not alone in the process. Mentorship is available to identify what a problem might be and how funding or changing programs is available to solve for it, and what programs specifically would meet your needs. In this example, this is a rural hospital in Michigan where our telecritical care support team was already up and running. It's a critical access hospital where we launched telecardiology. And in the last 4 months, they've already seen a 24% reduction in proportion of cardiology-related transfers, and had an increase in cardiology-related admissions, translating to 31 patients. And it's been a huge success. Next slide, please. Another example I just want to share, in rural Oregon, there was a hospital that we are partners with that was losing stable end-stage renal disease patients just because there was no local dialysis access within their institution. They were transferred for 2 hours away. So we have other services available, but we launched telenephrology with remote dialysis, and now all of those cases can stay. But I think the bigger conversation is how incredible that is for the local community. When we connect with the staff there and hear about how happy those patients are that their daughter who lives 10 minutes away can come visit them, that's huge, and that's really what drives us. So I think coming up with a strategic priority, realizing the financial value, supporting the program's long-term clinical viability, think big and curate your steps based on what your needs are. Next slide, please, Karsten, as we close. What are the first 3 steps? What are the steps? I think infrastructure readiness, what foundation is available, high-speed internet, IT, equipment, diagnostic tools, really using some of the grant money, or as a program, whatever your program needs are, prioritizing those needs. And the goal is not to rip and replace. It's to have workflow development, clinical design development that's collaborative, and investing in staff and protocol that uses the technology to support, not disrupt. And then communication, as I shared in the previous slide, it breeds efficiency, it translates into patient outcomes. And then leveraging part of the grant for data collection, monitoring metrics and compliance with grant reporting, and how to secure ongoing funding and sustain viability of the program. And I think the way we find success in that is making sure there's regular check-ins with the boots on the ground who are actually living out the workflows, but also the stakeholders and the champion that you've identified for the program. That's key. Next slide, please. Telehealth can solve for a lot of these problems. I think, as I mentioned, just in closing, right patient, right care, right place, right time, and hopefully that's in their most local environment. We put programs right in the ER because I think that's where the ability to keep them is, and that's where the flow of their journey starts the sooner. On the flip side, once the decision to admit is done, we want to move those patients to their inpatient space and take them 24/7 supported through the hospital bottlenecks and get them discharged as quickly as possible. So telehealth can absolutely put in programs in place to help support that. For example, using virtual nurses to push along admissions and discharges, maybe moving it to the morning so that you can unlock net capacity for beds. There's so many different strategies people have used to use telehealth to help with patient flow. And I think we haven't really talked about it, but there's definitely more opportunity for initiatives, sepsis, stroke. If you think about a tele provider in a closed, quiet setting, able to focus on quality metrics, that's really going to help drive institutional change as well on a local and larger level. And it offloads the staff from having to focus on those things while maintaining your mutual goals. And lastly, it isn't captured in any of the data I shared, but the relief and patient experience component, when a patient or their loved one meets their consultant within minutes, is huge. Think about that difficult conversation an intensivist can have, or the way a virtual nurse can be a mentor to a patient who's boarding. It's hard to measure those key components of time that get gifted back to the bedside when you augment with telehealth. And so as we, sort of close the conversation, I think success will mean different things to different organizations or people on this call. But I think building scalable programs should be a focus. And it doesn't mean having to hardwire everything. I think starting small even and thinking about what your problems are and coming up with partners to help you solve them. Thank you so much for your time. And I feel honored that I get to serve rural communities, and we're really passionate about the work we do. Feel free to reach out to me or anyone in our Equum organization. If you could advance the slide, Karsten, please. You could keep going, apologize. Got excited and passionate about my conversation, but you can connect with me here on LinkedIn, and I want to just give some time back to hear any questions, and thank you again, Angela, for your expertise.
Great, thank you so much for all the information, Angela and Dr. Mathur. I do want to note that we've had several questions about the slides because of the issues at the beginning. I will personally make sure that the slides get out. I apologize, technology was not our friend today, but we'll get through it. I did have a question come in, several questions. So Angela, I'm going to start with you if that's okay. Do you know any specific grant opportunities for nonprofits who would like to increase education and awareness?
I think that there are a lot of opportunities for that. It depends on what types of education and awareness. So I would suggest as a very baseline starting point to look to HRSA, which is the Health Resources and Services Administration, because many times those kinds of activities can be forwarded into HRSA opportunities. But you may find some disease specific, if that's where you're headed, or social determinants of health specific funding that might also meet those needs.
Great, thank you. Let's see, another question that has come in. Angela, what are some common challenges rural hospitals face when applying for federal telehealth grants, and how can they overcome them?
Yeah, I mean, that's a big one. I think it can be challenging to keep track of what funding is available and then be ready to respond. So we did talk about laying that groundwork, and I think that's really critical. Do as much homework as you can in advance of having a grant opportunity in front of you. And of course, certainly contact me and we can give you some tips and tricks as well. But I think doing that homework as a first step is going to be critical.
Great, thank you so much. Another question that has come in for Anisha. Transfers are a problem. Can you share can you share more specific examples of types of patients that can be retained through specialists?
Sure, thank you so much for that question. I think it is a complicated answer. It depends on the local institution, but part of the analysis of leakage is looking at what cases are lost and thinking through what the local resource availability is. With a specialty expert on board, would they be eligible to be retained? So all of that happens in the design phase to really understand a program's needs. But just to kind of shoot examples of current clients that we work with, I think patients with congestive heart failure with the support of a telecardiologist can absolutely stay. We take care of patients with single organ failure with sepsis with our telecritical care and tele-infectious disease team. So I think there's a lot of support available. It's hard to pinpoint just one syndrome. I will also say that the disease spectrum is really unlimited because we're also able to help patients who are boarding. So even if they have to go from the local institution, having that expert readily available, really there's no limits there.
Thank you so much. I think we have time for just a couple more questions. I want to make sure we get in our closing remarks, but Angela, can you provide more details on the USDA distance learning and telemedicine grant that's due March 6th?
Yeah, for sure. So that's a great opportunity for rural communities. Those grants are up to $1 million each. They do have a 15% match requirement. Now, you certainly don't have to apply for the full $1 million, but those grants are designed to provide you with the technology that's necessary to deliver telehealth. So what I mean by that is if you think about telehealth carts If you think about like an Amwell TB kit, for example, in an inpatient room, this is an opportunity to provide funding for that technology. And so think about the hardware and the software that powers that hardware. And then of course, peripherals and warranties and all of the things that come along with that. So it's a good opportunity. It's typically about, I think, $40 million to $60 million in each round. So they do fund a lot of projects, and it's one that we have a lot of good experience with, so happy to help there.
Great, thank you. We are going to run out of time and the questions are flowing in now. So I just want to let everyone in the audience know, if you have a question, please go ahead and put that in. What we don't get to, I know that we'll send on to the speakers to reach back out with the information you're asking for. What resources would you recommend for someone looking to gain education or knowledge in grant writing?
Oh, it's a great question. So I talked about the Rural Health Information Hub. They have a lot of great resources there. Grants.gov has some great tutorials on their website, and even the HRSA website, which is HRSA.gov, I believe. You can check out some resources there for grant writing. In addition to that, you can often find local workshops, sometimes at community colleges or economic development, that do some more hands-on in-person kind of training. So it's a great question. There's resources out there for sure.
All right, so one last question. I'm so sorry, everyone. I will again make sure the speakers get these questions and get back with you. Do you have suggestions for specific grants to help fund a new EHR for a small critical access hospital?
Yeah, that can be tricky, but there are funding there. I think that one of the things you would look to is definitely your state. State may have opportunities. That varies widely, though, by individual state. So look there. There are some other programs, probably too detailed to get into, but we can do some follow-up there. So yeah, definitely can help.
Great. All right. Thank you again, everyone, for your participation today. Again, I will send those slides out. I'm going to turn it back over to our speakers for closing remarks before I end our session.
Go ahead, Angela.
Okay, well, I just want to say thank you all again. It's been absolutely my honor, and we are here to help. So please connect and stay in touch. And as we hear more about the grant landscape, we'll certainly keep you posted.
Yeah. Thank you again to NRHA and everyone who joined today. As you can tell, we're both quite passionate about these topics. And so I think, as she said, connect with us. There's no question too small, and we're here to help make some meaningful change. So thank you for your time today.
Thank you. And thank you, everyone, for joining us today. We do hope this session provided you with some new insights and some ideas to take back to your organization. As a reminder, the session recording will be sent to you later today. I will also make sure we get those slides out to you. That way you can revisit anything you found helpful. Please don't forget that survey at the end. We do really take that information and apply it to this session to make sure you're always getting the most relevant information. If you're looking for additional ways to grow your leadership skills or expand your team's impact, please visit nrhasc.com for more resources, or you can always reach out to me. I am happy to help. Finally, we'd like to extend a special thank you to Equum Medical for their ongoing support as a gold partner with NRHA and for their commitment to improving rural health care. Have a great day, everyone, and we look forward to seeing you at our next session.
Thank you.